Good afternoon, everyone. I would like to start by sharing that since December 9, we have received 2 new wastewater sample results. I'm pleased to say that the signal has been steadily falling. Alongside robust diagnostic testing, which diagnosed 5 previously unknown cases, this falling signal is good evidence that there has been no further transmission. I would like to begin with a big thank you to everyone who came forward for COVID testing after some viruses had showed up in Yellowknife's wastewater. Because of you, we were able to get a much better idea of what was going on in Yellowknife as soon as we saw signs of trouble. Next, I would like to thank our frontline teams for their surge response to support the advice. Our health professionals completed more than 800 tests in 4 days, and they did it while minimizing wait times and disruptions for patients. The COVID Secretariat Contact Center staff completed 1,500 phone calls and emails to reach everyone subject to our advice proactively. They did that within 24 hours. They worked in lockstep to ensure everyone got the right advice. Everyone went above and beyond to rise to the challenge, and we are proud of how the system worked. This was possible because of the generous support from Indigenous Services Canada, the National Microbiology Laboratory, and Public Health Agency of Canada. They provided the funding to get wastewater testing off the ground, and today they are supporting us by testing the samples free of charge, as well as providing technical expertise. We are working to expand this program to other communities in the territory to strengthen our epidemiological surveillance. Knowing what's going on in our communities will go a long way to keeping us safe. Especially over the holidays, we will all need to take a good hard look at our behaviors. As many join their families and friends from across the country, cases across every region of Canada continue to rise. This means our risk of introducing COVID-19 in our communities has never been higher. So we can't rely simply on the government response to this virus. We need to rely on each other more than ever. To keep yourself, your family, and your friends and your communities safe, making healthy habits we know now stop COVID-19 part of our daily lives is the best thing we can do. Commit to keeping physical distance of 6 feet between yourself and others. Commit to wearing your mask when you're in public spaces to double your protection. Commit to small crowds and large spaces to stop COVID-19's journey from person to person. Commit to washing your hands frequently. Commit to keeping your coughs and sneezes to yourself. Commit to staying home at the first sign of sickness and arranging for COVID-19 testing at your local health center or public health unit when you do. And commit to sticking to self-isolating responsibly as a household or in a self-contained unit, and applying some positive peer pressure to your friends to do the same. Now is the time to roll up our sleeves and put in this work to keep each other safe. If we do, we'll all be in a better position when we roll up our sleeves to get vaccinated. As we prepare, we are working closely with Indigenous governments and community leaders. Yesterday, we met with Indigenous governments. Today, we met with community leadership. We had a lot of good discussion about priority groups for vaccine rollout, the importance of communication across our official languages, and the logistics of getting these vaccines to communities. These perspectives will help us finalize a plan reflecting our territory's values. And these relationships will prepare us to lead together and speak with one voice as we encourage folks to get vaccinated as soon as they're eligible. We do look forward to sharing more updates as they're available. And I do want to finish by talking about the importance of continued vigilance, even as we work towards an exciting new stage in our pandemic response. COVID-19 will remain our higher risk for months to come. There'll will still be thousands of new cases a day across Canada for some time. And this means there will still be a risk for us. So we can't let our guards down in the meantime. But let me be clear. As vaccination levels rise locally and nationally, we can expect more freedom and greater safety. We will make changes to self-isolation protocols, travel restrictions, and gathering limits as vaccination levels rise in the NWT and as risk falls for invitation across Canada. And we'll be able to make them soon if we all do our part over this crucial holiday season. Thank you.
And thank you, Dr. Kandola, for your remarks. And we're going to move to the question and answer section. And just a reminder, it's one question, one follow-up for each outlet. And if you wish to turn your camera on, you can while you're speaking in order to conserve bandwidth. We'll keep it to that. And today I'd like to begin with Amy Tucker at CBC North.
Hi, no questions from me, thanks.
Okay, thanks, Amy. And I'd like to go to Bailey Morton at True North FM.
Hi, can you guys hear me?
Loud and clear, Bailey.
All right, thanks, Mike. Thanks, Dr. Kandola. I was wondering, Dr. Kandola, if you could go into a bit more details about how public health was able to manage this surge, completing 800 tests in 4 days. Like, what did the efforts look like?
Thank you. So first we had the public health advisory outlining the dates and times that people who would be self-isolating in that risk period should come forth to get tested. We had Protect and the BT call in 1,500 people who fell into that age group. And then we had public health and the COVID clinic do the surge response in terms of having people come forward and testing them. The labs were able to pool the test results and be able to run large batches at one time. And when there was a positive, they were able to separate them and rerun them and find out exactly who was positive. It did create a surge. People worked extended hours, and it was an adequate response, an excellent response to seeing an increase in wastewater signal, but it can't be the norm. We cannot be living in a surge mode every single day. We have to restrict those periods when we call staff to go above and beyond and work many overtime hours to a true signal of distress or a true call out to say that we need to be finding out what's causing this wastewater signal, or there's an outbreak and we need to be testing as many people as possible. Thank you.
And one follow-up for you, Bailey.
Yeah, thanks. So I'm sure you've talked about this before, Dr. Kandola, but I was wondering if you could outline how you're going to manage the surges that you expect to come in the holiday period, considering what you just said about the demand that it's put on staff this past week.
So we have a lot of different layers. One, wastewater surveillance will continue. In Yellowknife, we collect the samples 3 times a week, but it's a continuous sample. We're collecting in other communities as well, twice a week. So that basic wastewater surveillance will continue throughout the holidays. The second is that we have rolled out point of care tests in a number of communities, Hay River, Bay Choco, Normal Wells, Fort Simpson, Fort Smith, in addition to having the testing capacity in Stanton and in Inuvik. We're also, so we rolled out point of care test, which is ID now, which is a molecular test. We're also rolling out PAM bio tests, which are rapid antigen tests, and we're trying to have that rolled out before Christmas. So that gives communities and gives the hubs the ability to test any symptomatic client as quickly as possible. So that increases our capacity over the holidays. The third is a targeted screening of high-risk essential workers, such as healthcare workers, dentists, RCMP, anyone that works in crowded settings, correctional officers, so that even though they have symptoms, we do targeted screening on day 1, day 8. And fourth, and this is where we need the help of the public, when we are expecting an increase in the number of travelers coming in over the Christmas holidays, but we also know that a lot of people are traveling out. There'll be 2 surge blips. One will be the increase in travelers coming in over the Christmas holidays, like as of now, and then there'll be another increased surge the first week of January, around January 3rd and January 4th, as people are returning back into NWT who've traveled down south. Both scenarios do provide an increased risk. We are looking at over 6,500 daily cases of COVID. It's across all provinces, particularly the larger provinces, and we know a lot of people are traveling down south. Alberta has over 20,000 active cases, so we know there's going to be an increased risk of picking up COVID when you're traveling out to visit your loved ones. We highly recommend to avoid non-essential travel, but we do understand that's a risk, and we also know there's a risk of importation as those friends and family come into NWT and visit their relatives here. What we are asking, and this has worked really well when we look in the past few weeks looking at our cases, is that number one, if you are traveling out of territory, you are required to isolate for 14 days, and your entire household is required to isolate for 14 days. And finally, if you have any signs of COVID symptoms, we're asking for you to call the health center, the public health unit, and get tested right away. If all those 3 can be done with minimal contact with other people, then we can contain COVID over the holidays. We can contain it as a travel-related risk only and not as a community transmission risk.
Thank you, Dr. Kandola. And I'll move to Luke Carroll at CKLB Radio. Luke, do I have you? Okay, we're going to come back to Luke. I'm going to go to Mario DiCiccio at Radio Canada.
Hi there. Good afternoon, Dr. Kandola and everybody else. Just maybe a word on what Prime Minister said yesterday, that the territories are scheduled to receive doses of the Moderna vaccine, I guess in the coming weeks. That's a bit sooner than expected. What do we have to say about these first doses that we're going to receive?
So the most important information we're waiting on is actual Health Canada approval of the Moderna vaccine. The Moderna vaccine is advanced in the regulatory review process, but Health Canada actually has to approve the vaccine before we can administer it to our residents. So that's the first piece of news that we're all eagerly waiting for. After that, there was an announcement of 168,000 doses that will be going out to the provinces and territories. And so we have received the fridges, both in Inuvik and Stanton, and this week, and so they're plugged in, and we're doing cold chain monitoring. We can receive the initial shipments, but we still have to go through training, hiring. We had spoken to the Indigenous communities and to the municipalities, and one common theme was they are asking that we provide information around the vaccine in language that in Indigenous languages, and in a manner that they can communicate to elders so they can have informed consent before they um, receive the vaccine. So there are still, even if we receive the shipment, there's still hiring, logistics, communication, making sure that the NWT residents have the information they need to provide informed consents before we distribute the vaccine. So we're anticipating that probably around mid-January, hopefully if the shipments arrive, that we can start rolling out the vaccines to priority populations.
Perfect. That was actually my next question. So you're estimating in mid-January, regardless of the shipping or the approval, your team will be ready by mid-January to with all the training and all that passed. So I guess just to follow up, I know you mentioned it before, but you were meeting with community members and leaders, Indigenous leaders. What can you tell us of what's coming out of these discussions? When we're talking about priority groups, is there anything new? I know we're waiting for more news on that. So what can you tell us today?
Well, we literally had the Indigenous discussion with Indigenous governments yesterday, and with the communities, it was this morning. So we're synthesizing all those comments and we're incorporating them into our vaccination rollout plan. But communication was a common theme. Another theme was making sure there was an independent review of the vaccine, so that that we know that the vaccine is safe and efficacious, but it's done by an independent body. And so we have two types of independent reviews. We have the regulatory review by Health Canada, and then we have the National Advisory Committee on Immunization, NACI, who does another expert review. Both their reviews will be pivotal in how we can communicate back around safety and efficacy. The other common themes were around priority groups, and it was just more of questions of additional priority groups and when they can see the vaccine and being delivered. And so those are the common themes. We'll have more of that synthesis written up and provided in the vaccination rollout, but that was just off the cuff some of the common themes I heard.
Thank you, Dr. Kandola, and certainly some very exciting discussions, and a lot more to come on that. Stay tuned. We're going to go to Megan Brackenberry at Cabin now for a question and a follow-up.
Hi, everybody. Thank you so much for having me on the call today. So my first question was, I know that the vaccine freezers are in Inuvik and Yellowknife, and that you said that the vaccines will obviously be distributed to other communities as well. My question is, how exactly are you planning on distributing the vaccines and making sure they stay usable within smaller communities, especially if they don't have those freezers?
Yeah, that's all a part of the logistics component. The vaccines have to be stored at -20 for storage, and the logistics component is about having portable freezers to bring a small supply when they charter the planes and when the mobile teams go out, that they can maintain that cold chain link and storage at that temperature with portable freezers. So this is all being worked out as we speak, and this is part of their logistics preparation before people roll out and deliver the vaccines. As that's been prepared, the most important component also is communication. What was a common theme is that people want communication to start as soon as possible. When we get the vaccine approved, any questions around vaccine hesitancy, or concerns, they want that addressed as well. So even though we're working out this logistics of how to keep the cold chain going from the Stanton, from Inuvik and Yellowknife down to the small communities, that's being figured out. We still have to make sure people have the communication they need ahead of time too.
One follow-up for you, Megan?
Yeah, perfect. And I know too, you said obviously, as we were discussing before, you have met with Indigenous governments and community leaders. And in your last announcements regarding the vaccine, the NWT has said it will be prioritizing those who are at risk of severe disease, as well as those at high risk of bringing COVID-19 back into the territory. So because of these discussions, is there any more that you can elaborate on this time to break down exactly what that previous definition entails and who that covers?
So those are guiding principles, and we have 4 categories of groups that fall in those guiding principles. But depending on the amount of vaccine we get on the first shipment and the second shipment, the coverage within that group can vary. But pretty much the highest risk category are the elders, and we know that you start seeing increase in severity after age 60, and the older you are, the higher the risk of severity. And within that group, there are even more vulnerable populations of people working in long-term care and people who are elders with comorbid conditions. So elders is one category. Second category are those that have high risk medical conditions. They have chronic kidney disease, lung disease or heart disease, uncontrolled diabetes. We do know that even if they're not an elder, if they have these conditions, that if they do get COVID, that there are an increased risk for severity, which is increased risk of severities and admission to hospital, ICU, and that is how we define it. So that's another category of people. Within that, when you add a number of those people with those comorbid conditions also travel down south to Edmonton to get specialized medical care, that puts them at a double whammy situation where they're going into a province that has a high number of active cases, a significant number of them in Edmonton, and also experiencing outbreaks in their healthcare facilities. So that puts that individual high risk of picking up COVID and bringing it back. And then unfortunately, because of their conditions, high risk for severity. Third one are essential workers, high risk workers that work with vulnerable populations. The ones that we think about are physicians, frontline healthcare workers, but they could also be people who work in shelters, or they could be workers who live here and work frequently in other jurisdictions, whether they work in the oil and gas or in mines or are pilots. Because they're traveling so often, coming back, they will be increased risk of bringing in COVID. And the final and significant category are our remote Indigenous communities, especially those communities that are completely fly-in or cabin communities where there's no health systems in place, that they're particularly vulnerable as communities in if they do have COVID introduced in terms of quick transmission. And we've seen that in a number of jurisdictions across Canada, in Manitoba, in northern Saskatchewan, and in Nunavut.
Thank you, Dr. Kandola. And we're going to go to Richard Gleason at CBC North now.
Yeah, at that meeting that Mario mentioned yesterday in Ottawa, federal officials said that they're expecting a total of 6,000 early doses of the Pfizer and Moderna vaccines in the first quarter of 2021. And they also said that they're going to be distributed on a per capita basis. The territorial governments, all 3 of them, have said that they're planning to vaccinate 75% of the adult population in the first quarter, which would require more than a per capita share of those early doses. Can you just sort of help clear up that discrepancy?
I can tell you what we've been told and what we've been promised. On Thursday, there was a First Minister's meeting, and it was brought forward there that all the territories like Yukon, Nunavut, Northwest Territories, we as a territory, given our remoteness, given our limited health infrastructure, we would be considered as a vulnerable priority population. And what was agreed was that for NWT, we'd be provided enough vaccine to vaccinate 75% of our eligible population, which would be 18 years and older. And that would come out to about 51,600 doses. That's 2 doses. So this is what was committed, and this is what we're working with.
Okay. All right. And you mentioned that you were talking just a moment ago about the priority groups. Do you have any sense of when, within the first quarter before March, members of the general public who are not considered priority groups might be getting the vaccine?
So what we're working with is an expectation that we would get the dose of the shipment for the priority group end of December, early January, and we can roll out in mid-January. That's our expectations. What we're hoping is that within 3 to 4 weeks of receiving our first shipment, we can receive our second shipment. We don't know what that amount is. So depending on that amount we get for the second shipment, if we have enough to provide the second dose for our priority group and there's vaccines left over, we could, in the second shipment, start out offering to the general population, but we don't know. We may only, in the second shipment, have enough for the priority populations, and it's the third shipment, the February one, where we can actually roll out to the general public. We're hoping, and we don't have confirmation, we will hope that the second shipment we could wrap up the priority groups and start working with the general population. But I don't have any information to confirm that, but as soon as we do, we'll definitely let you know.
Okay, thanks.
Thanks for those questions, Richard. And we'll move to Paul Bickford at the Hay River Hub. Paul, are you with us?
Mike, can you hear me?
I can now. Go ahead,
Okay,
Paul.
great. Thank you. Dr. Kandola, I was wondering if you could provide an update on the first case in Hay River, maybe how that patient is doing, if there are any other people in self-isolation as a result of the flight. And I guess on the weekend you said the situation was under control. I'm just wondering if you could provide a sort of like a general update on the case here.
So we don't talk specifically about the cases, but what we can say is in the public health advisory is that all the right things were done. A person was self-isolated, had symptoms, got tested, was interviewed, and their close contacts were isolating. So from that investigation, it seemed pretty contained. One of the scenarios that you do see in this public health advisory that's different is that we always look at travel history and looking at when people develop symptoms or when they're on the infectious period. We determined that during the flights that we would follow the normal protocol, that if there's a potential that the person was in their infectious period while they were traveling, even though the risk of transmissibility is quite low, the protocol would be to alert Public Health Agency of Canada, provide the flight numbers, and then contact the people 3 rows in front of, 3 rows behind the client, and provide those rows in a public format, which is what we did with the public health advisory. And then we would ask all those contacts to get tested on day 10. Today is Wednesday, so it would be day 12. And as far as we know, there hasn't been any transmission based on the 2 flights. Everyone else is isolated as we speak, and this scenario is contained. One of the things I do want to ask people, and it was in my speech, we will get cases of COVID, and I think we shouldn't be surprised if we get cases of COVID. The situation in the southern provinces, the number of cases are increasing. They're daily breaking new records. That we're in a pandemic, and in our major cities, the provinces are doing the best to contain it. They're introducing new restrictions, but it's not going down. Canada is still on increased path of increase in transmission, increase in number of cases. So the choice is yours. This is not the time. The vaccine is so close. It's just around the corner for priority groups. Do you really need to do that non-essential trip now? Do you have to have your relatives come now? Or can you just wait a little while longer until we can all get our first dose and second dose? And I'm literally saying weeks. If we continue traveling out, non-essential, and we continue having our relatives visit from these areas, then expect more cases over the next 5 weeks.
And one follow-up for you, Paul?
Okay, thanks. So, Dr. Kandola, did I understand you that so there was no testing to confirm that there's been, except for the patient, I guess, but are there any, aside from the patient, are there still people in self-isolation? I would assume they're still in self-isolation, correct? And can you tell me how many?
I can't tell you how many, but if what we do recommend in those rows when we send out the information that they self-isolate for 14 days from the date of travel and that they get tested on day 10.
Okay.
Thanks for that, Paul. And we're going to circle back to Luke Carroll at CKLB and wonder if got the technical issue sorted out there.
Can you guys hear me now?
Got you now, Luke.
Sweet. Sorry about that. So I got a question for you, Dr. Kandola. When you oversaw the 2009 H1N1 vaccine distribution, were there any of these same challenges about communication with Indigenous languages in the communities? And if so, what did you do to deal with that?
So that was about 11 years ago, and we would have, instead of you use radio ads, you would provide messaging in Indigenous languages, and we rolled out in mobile teams. One thing that we did learn that we'll do differently is some of the community said the mobiles team came, they touched down, they vaccinated people, and they left, and there wasn't this engagement with the community or even inviting community members to help them out with the vaccine rollout, whether it's setting up the immunization area or providing accommodations or getting the patients to come in. So what we did learn from that is that communities wanted more engagement and they want to be involved. So even providing the radio ads in Indigenous languages, providing the communication, it's beyond just that. Is when the mobile teams go out, they want to be involved in the process.
Thanks, Dr. Kandola. And actually, Luke, go for your follow-up, and then I have a suggestion now that we're on the topic of the H1N1 vaccination campaign. But go ahead.
Sure, thank you. So yeah, I was just wondering, is there any plans to hire like translators or interpreters for this vaccine rollout plan?
So, because elders are, it's interesting with the H1N1, it seemed to be mainly the severity was targeted among younger people, but with this COVID, which is a different virus, which COVID-19, it's targeting the elders. So we need to, the difference is we need to involve interpreters, and we need to have information available in Indigenous languages and also in a way that elders can understand, because this is a vaccine that impacts them. It's a vaccine with a new platform in terms of new delivery mechanism that hasn't been tried before, other than the Pfizer vaccine. So with all this information and what they're seeing, like they need to have as much communication as possible, not only in radios, but with interpreters, or even with, if we can find healthcare workers that speak Indigenous languages, that would be awesome as well. But we're going to try at every single avenue to make sure that when an elder rolls up their sleeve to get the vaccine, that they know what they're getting and they know why they're getting it, and they have information about the next dose, any potential side effects, that they have all the information they need.
Great. And just from a GNWT perspective, Luke, I would say that we have a French languages secretariat and an Indigenous languages secretariat who have both interpreters on staff and strong relationships with contractors from all official languages across the communities who will be using quite extensively, as well as community health representatives on the ground who speak local Indigenous languages who we already work with on a regular basis. And while we're on the topic of the H1N1 vaccination campaign, Dr. Kandola, I wondered if you might want to mention, the uptake at that point, because we were the second highest in Canada, and I thought you might go into some detail about, how we did that and what that meant actually in a numbers perspective.
So, yeah, so I think we had overall target immunization of 63%. It was the entire population, so it did include 6 months and older. And so that's 63% of the entire population. That was a pretty good goal when you look across Canada. What was really beneficial was that just like with the COVID-19, we did get all our vaccines in one allotment, whereas the rest of the provinces still had to prioritize. And that's what's going to happen this year too. Like in 4-to-1, most of the provinces only going to get enough of 5 to 10%. So that was good that we had enough to immunize the entire communities. And it was all about logistics, communication, and setting up the mobile teams. Some communities had a stronger infrastructure, so they had some great nurses and public health nurses on the ground, and they said, like, we're ready to go. We can do it on our own. Just give us a logistician and some supplemental support, but we can roll with it. And so it was all about planning, communication, getting the logistics going in, and then vaccinating in a short defined period, and then moving on to the next community. It was done relatively quickly. The difference with H1N1 and COVID is we have to come back for the second dose. But we did see a dramatic difference. We did see a dramatic decrease in H1N1 cases in NWT after we rolled out the vaccination program.
Great, thanks, Dr. Kandola. I'm going to move to Veronique Picard with Radio Canada.
Hi, Dr. Kandola. We talked a lot about Indigenous communities, but I have another question. With what you know so far concerning the number of vaccines you will receive, do you think you will be able to vaccinate all of the 33 Indigenous communities in the territory, or did you target some priority communities within the Indigenous communities?
Thank you for that question. So we have to do a lot of modeling. So there are, when you look at our risk groups, there are, in every community we have elders. Every community will have people with high risk conditions. We have healthcare workers and other high risk workers. And then when you go into the Indigenous and remote communities, we know that some communities are more vulnerable than others. So we're looking at their health system infrastructure. So when you're looking at cabin communities, they don't have a permanent nurse there 24/7. So they're particularly vulnerable if COVID was introduced, because it spread pretty quickly, and they don't have that support staff 24/7. So that would make them a priority group to try to immunize all their adults as quickly as possible. They tend to be small communities. The other communities that are vulnerable are the ones who are flying in all year round, such as Sax Harbor, Gulhaktuk, and Paulatuk. They're primarily flying communities, and it makes it vulnerable. So should there be an outbreak in those communities and several elders need the ambulance, it will put a significant strain on healthcare resources. The next priority are communities that are vulnerable and increased vulnerability are communities that they do have a health center, but they're away from a regional health center that has more increased capacity. They're away from the hospital or a more robust healthcare facilities such as the Fort Smith, Hay River, Yellowknife, and Inuvik. So these are typically two-person health centers. And so that would put those communities at risk. So that would be, we'd consider them more vulnerable. And then within all the other regional centers and main hubs, it will be the same category: elders, those who have high risk conditions, and those who work with people who are vulnerable or travel frequently in and out of NWT, so high risk of importation.
Thank you. Did you have one follow-up, Veronique?
No, thank you.
Thank you. And we'll go to Simon Whitehouse at Northern News Services.
Good afternoon, Doctor. You mentioned, I don't know, you stated just around the corner a couple of times. I'm just wondering, do you have any sense of just how widespread the vaccination has to be to loosen border restrictions?
So the we would have to see the uptake in the general population. Even if we immunize the priority populations, that wouldn't be significant enough. We have to understand that NWT doesn't live in an island, so our aim is to offer the vaccine to up to 75% of the adult population, but at the same time we still have to recognize that the rest of Canada are not going to get their full allotment until later, and so there's still high rates of COVID occurring. There's still a high number of travelers coming, and we still have a population of children that are unimmunized, and so we don't want to be in a situation where we can have school outbreaks and impact on teachers. So we will monitor the situation, and as we get more and more people vaccinated, and as we see the second wave go down, we can then talk about relaxing some of the orders. But it won't be, we won't be able to get there till mid to late February to even start discussing it, because we're only rolling out our first dose in mid-January, and we need 2 doses to consider someone adequately immunized.
One follow-up for you, Simon?
Sure. This is just more of a recap question, I guess. It looks, you mentioned mid-January would tentatively would be the initial rollout. So between now and then, you've got, we're waiting for Health Canada approval. There's a vaccination plan, communications campaign, and independent inquiries on the doses. Is that right? Or could you just recap?
Between now and mid-January, we're waiting for Health Canada approval of the Moderna vaccine. We're waiting for to receive the first shipment of Moderna vaccine. We're waiting for National Advisory Committee on Immunizations to provide safety and recommendations around this vaccine. We're in the interim going to be rolling out a vaccination rollout plan. We'll be working on communications. We're going to be working on hiring and training, making sure that we have the immunization training and requirements to roll out mass vaccination with the healthcare staff. And then we have to work around the logistics of organizing charter flights and when we can go into communities and booking accommodations, because sometimes we're going to have to overnight, and we have to make sure that the flight crew can and the vaccination crew can actually have a place to stay and that the hotels are not booked. So there's all these logistics that need to happen between December 16th and mid-January. So it's less than a month.
Wow. Nice.
Yeah, thank you, Doctor, and thank you, Simon, for your questions. I don't see anybody else that we've missed on the line here, so we do want to try and run through a few more while we got a bit of time here. So I'm going to go back up to Luke at CKLB.
I'm good. No further questions. Thank you.
Great. Yeah, and we'll go to Mario DiCiccio at Radio Canada.
All good for me as well. Thanks, everybody.
Thanks, Mario. And to Megan Brackenberry at Cabin Radio.
Just a quick one, and sorry if I'm making you repeat yourself. Do you have a timeline on when we can expect the vaccination rollout plan to be finished?
So we completed the Indigenous government engagement yesterday, and then the community engagement was literally about less than 3 hours ago. That was just wrapped up. We're incorporating their comments in the vaccine rollout, and we're working as hard as fast as we can to have a vaccine rollout available. Can't give you hard timelines, but we definitely need it between now and mid-January, but we're going to be working as fast as we can to get it rolled out in the next week or so.
Thanks. And are you good there, Megan?
Yep, I'm good. Thank you so much, everyone.
Great. Thanks, Megan. We'll go to Richard Gleason at CBC North for any final questions.
No, I'm fine, thank you.
Thanks for coming, Richard. And we'll go to Veronique Picard. Any final questions?
All good, thank you.
Thank you. And we'll go to Paul Bickford at Hay River Hub.
Can you hear me now?
I can. Go for it, Paul.
You put yourself on mute, Paul.
You cut out again, Paul. One more try here.
Ooh. Mike, can you hear me?
Yep, I got you.
Okay, I think you were trying to unmute me, and I was trying to unmute. Oh well, whatever. Dr. Kandola, I was just wondering about this process of somebody flying into Yellowknife on a commercial flight, and normally, I guess when people fly in from outside of the territories, they had to go into self-isolation. But if they're going to another hub, they can fly from Yellowknife to say Hay River or Inuvik, or I guess even Fort Smith if there are flights. Is that the way it's supposed to work? Like people flying into Yellowknife, are they supposed to isolate there or before they travel on, or they can travel on to those other isolation centers?
So there's 4 isolation centers: Inuvik, Yellowknife, Hay River, and Fort Smith. And so when people come into the territories, the most common flight will be Calgary or Edmonton going into Yellowknife. So it's not only people going to isolation centers, but people going home. So people who live in Fort Smith and can safely isolate at home, they don't necessarily want to be in Yellowknife. So they are allowed to go on to their point of destination as long as it's those 4 hubs, which is Hay River, Inuvik, and Fort Smith. So if you land in Yellowknife and you live in any of those 3 communities, or you plan to isolate in those 3 communities, you can continue to go on. We just ask that people wear a mask, they physically distance, and abide by those public health rules.
Can I have a quick follow-up to that, Mike?
Yep, quick one, Paul.
So, considering what happened here in Hay River, and these guidelines or that process is not going to be reevaluated, it sort of seems to me, going by memory, something like that may have happened in Inuvik. I could be wrong on that earlier on in the pandemic, but this is not going to be reevaluated, that process or way of traveling.
So we've been the actual risk of transmission is quite low if people are wearing the mask. The flight duration from Yellowknife to Hay River to Fort Smith is quite low. What we have discussed with airlines is that Yellowknife to Norman Wells Inuvik portion, which is a longer flight, is that if there's consideration of separating those who coming out of territories with those who are traveling within, if that could be considered. But myself as NWC Chief Public Health Officer, I don't have jurisdiction on the actual flight itself and how seats are arranged. It's under federal jurisdiction and under Transport Canada rules.
Thank you.
And Paul, there hasn't been exposure notifications in the same way with Inuvik, but I know what you're referring to. I can send you the statement that we provided on a few occasions on this topic as well. And I would just like to go to Thomas Etier at Radio Taiga now. Thomas, are you trying to speak, Thomas? You might be on mute. Okay, I'm not hearing any from Thomas. And that will bring this press conference to a close today. Thank you everybody for making time.